I think it's 10 p.m. his time, and he's able to join us. So glad to see Dr. Zembe being able to join us. I'm Julie Pullerwitz, and I'm one of the co-chairs of the relatively new Global Scientific Interest Group at the DC CFAR. And so glad you could join us today. This group has been around about a year at this point, or actually less than a year. I just joined in October, and we're really pleased to be able to came about after a discussion about World AIDS Day. And wouldn't it be great to have colleagues from UNAIDS come to share with us sort of an update on the global status of the epidemic as well as the response. And that's what we're going to be focusing on today. Next slide, Vivian. So the organizers of our scientific interest group include myself, again, Julie Pullerwitz from the Population Council, and my co-chair, Natella Rahmanana, who's also with us, and Khadija Abdullah, who is also with us, going to be with us online, who is our community lead, and Vivian Kirkham, who is our very helpful administrative support. Next slide, please. The overarching goal of our new group is to seek a platform for collaboration, and here we're representing that today, capacity strengthening and the sharing of best practices to improve HIV outcomes. And as we talked about it, we're interested in both local and global issues, strategies and methodologies, and sharing across academia, community-based organizations and governments, as well as the CFAR investigators and the national networks and regional networks and our partners. So one big focus we have been talking about is trying to bring lessons learned from global work to the domestic setting, as well as vice versa. And so we welcome colleagues that work domestically and are interested in informing the global world, as well as those who work internationally to inform the local environment. And we'll be talking a little bit more about that later. So we, I think next slide, please. So here is our agenda for today. We're going to be together for the next 55 minutes. I'm Julie Pullerwitz with the welcome introduction, and then I'll be turning it over to our presenter, Lysias Zembe. We'll have some time for comments and questions for Lysias. And then the very last section of our time, we hope to speak at least a bit about what we would like to do in 2023, including a meeting in January around collaboration, potential collaborations amongst CFAR and other researchers. So without further ado, I'd like to introduce our presenter. We have today Dr. Lysias Zembe, who is an advisor at UNAIDS in the HIV Prevention Coalition and Adolescent Health in the Division of Science and Services. So his presentation will include kind of an overview of the state of the epidemic, an update on HIV prevention response and priorities in particular, since you've been very engaged with that recently, and then finally some new developments for addressing key issues for men and HIV, since this is one of Lysias's technical areas as well. And he's currently in Thailand for an important UNAIDS meeting to talk about these issues. So he's going to be sharing with us. So thanks so much, Lysias, for joining us. And I turn it over to you.
Thank you, Julie, and good morning, everyone. Greetings from Chiang Mai in Thailand. As Julie has highlighted, it's 10 p.m. here, and the meeting is still ongoing. The PCD meeting is still ongoing. They're doing some decision points with the different member states at the moment, and they're talking about CSE. As you know, CSE is a highly contested topic with the different countries. They've got different views about CSE, especially CSE in schools. So that's what they are talking about now to come up to some conclusion about it. So I'll try to capture different things in this presentation. The aim is to zoom in on men and HIV, but I'll try to give first a global overview and see where that is situated within the global HIV response, and then within the prevention response, specifically for men and adolescent boys. The first slide here, it's showing the bigger picture impact over time, or the number of new HIV infections decline over time. And on the right panel is showing AIDS-related deaths over time since 1990 for both charts. Basically, we use these graphs to show that the HIV response is far from reaching the epidemiologic targets that are set globally. If you look on the left there, you can see that the trajectory of the line is going to miss the 2025 targets in line with the new global AIDS strategy, which is timed to 2025. If we are to meet the 2025 targets, we need the line to kind of adjust its trajectory and become a bit more steeper downwards, as shown by that dotted blue line, if we are to meet the targets. Also, with AIDS-related deaths, we can see we are not on track to meet the AIDS-related death targets for 2025. If you take that the data, similar data, but in this case, in terms of HIV incidence, and you cluster countries in terms of those who are doing well and those who are not doing well, you get those clustering of countries for the different regions. So this table here is just showing countries that have achieved epidemic transition, which is quite a big discussion, big topic in terms of what are the definitions. So UN has developed some metrics of what we mean by epidemiological transition there, epidemic transition. Those are the 31 countries that have achieved that across the different regions. Then when you also analyze similar data in terms of HIV testing, people on treatment, as well as achieving viral load suppression, which is the cascade, you find that different countries and different regions, they're doing differently, or they're making progress differently. If you look at the first panel, the one on top is showing the cascade, comparing different regions also to the global aggregated progress. The conclusion from that panel is there's no region that has achieved the 95 targets. Some countries have achieved 90 targets, as shown by the bottom panel. The region that has done maybe better, we see that 63% in MENA and 91% in WCA. That is the variation that is shown there in terms of knowledge of HIV status if you compare the different regions. And then an analysis of the HIV estimates data also indicate that we have a huge gap when it comes to children. Those charts are shown by, they're shown for adults, but children data also shows that, or PMTCT analysis data also shows that children are really being left behind. So that is the bigger picture in terms of the main outcomes of what we want to achieve in terms of reducing HIV incidence to meet the 2025 global targets, when you compare it also by different regions. Then there's been a growing interest and focus on HIV prevention. But before I get to what has been the recent discussions, I would like to show you here, shown on the slide, what were the 2020 targets. I think we used to talk a lot about fast-track targets at some point until 2020. So for prevention, the fast-track targets, or there was a model which was saying, if we want to be on track to ending AIDS by 2030, by 2020, for prevention, we're supposed to have 90% coverage of key populations, or 90% of key populations have been reached with dedicated programs for key populations by their different disaggregations. 90% of adolescent girls and young women in key locations also have been reached with dedicated programs for adolescent girls and young women. These are programs, for example, like the DREAMS program or the Global Fund Adolescent Girls and Young Women programs. It was also modeled that we need to distribute more than 6 billion condoms in sub-Saharan Africa per year, and have 3 million people on PrEP by 2020, and 25 million voluntary medical circumcisions were supposed to be done between 2016 and 2020. These were the prevention pillars, or the prevention targets that were set to be achieved by 2020. But when you look on the right panel with a red heading, where we landed in comparison to the targets, only, in fact, less than half of the key populations were reached, that is around 42% on average, instead of 90% that we wanted. Also, when you look at adolescent girls and young men programs, only 44% of high incidence districts that were supposed to reach 90% of them, but only 44% were reached. For condoms, just over 3 billion condoms were distributed per year instead of 6 billion per year. And we only had 800,000 people on PrEP by 2020 instead of 3 million, very far from the target. And for VMMC, 18 million VMMCs were conducted between 2016 and 2020, far from reaching the 25 million that were supposed to be conducted between the same period. Also, there were targets to do with funding for HIV prevention. That is, it was modeled that we need to increase funding to 6.5 billion per year in low and middle income countries. But there was no increase in HIV prevention funding over those years. The funding was flat, or there was no increase as the model was predicting. And because of that, we can see how the trajectory of the line it looked like in terms of reducing new HIV infections. We saw in the previous slides, also summarized on this chart here. The blue line is what we wanted, but what we did was is the one that is shown with the red line there in terms of meeting the 2020 targets. Then after having that reflection, there's been renewed interest on prevention, a renewed focus on prevention. And this slide here is showing some of the key guiding documents or frameworks. When we discuss about prevention and we present in different workshops, I always say these are some of the basic documents that someone working in the HIV response might need to have come across and looked at. First is the Global AIDS Strategy 2021 to 2026, which has got programmatic HIV prevention targets. And then there's the 2021 Political Declaration on HIV and AIDS, which has got some commitments on HIV prevention. And this is set at the highest level where member states commit to these targets. And then there's the 2030, which is kind of the bigger picture, 2030 Agenda for Sustainable Development, where you find the different SDGs speaking to the specifics in different areas, including health. Then in the Global AIDS Strategy, the first or one of those guiding frameworks, Global AIDS Strategy 2021 to 2026, Ending Inequalities and AIDS, and the Political Declaration, which is also linked to the Global AIDS Strategy, because the commitments are made in line with the Global AIDS Strategy. We have got those targets, the 95 targets, and also we've got the 10-10-10 societal enablers. You can have detailed look at these targets when you read the Global AIDS Strategy. They're included in the annex. For the first time, these targets are very granular. They will take time for someone to really understand them, because they are set by different age bands, by different locations with the different HIV incidences, by disaggregations of sex, very detailed for different populations and also for different interventions. I think it's really a good document to read, and also the section on targets, which is put in the annex, a very good part of the document to really read if you are to implement any programs or advise on HIV programs as well. In that Global AIDS Strategy, this slide is showing what is different from the previous Global AIDS strategies. First of all, there's a focus on ending inequalities. If you analyze different HIV interventions data, you show that there are different lanes of inequalities that are reflected in that data. For example, if you analyze VMMC data, it will show you that men from high wealth quintiles are more likely to report being circumcised compared to men from low quintile or low wealth quintiles. So there are different lenses that you can use, inequality lens you can use to analyze the HIV response data that shows very striking results. Also, there's an emphasis on being granular, precision prevention, as they use that terminology, especially with the Global Fund. But as I highlighted in the previous slide, the targets are really granular, looking at data by age disaggregations, by different sex disaggregations, by different populations and locations. And there's a strong emphasis and focus on the prioritized combination HIV prevention. I'll speak more about this when I introduce the different pillars, the framing by which we try to look at HIV prevention so that we can monitor progress. And then also a focus on key populations, seeing how HIV incidence is high in these populations and the high risk, and their contributions to the new infections every year growing year by year. There's a strong focus on key populations there. And also U equals to U, a very powerful concept here for ensuring that we keep HIV infections very low. And then there are also other aspects around community leadership, very strong emphasis on working with communities, community-led responses as well as other aspects that have been in the previous strategies, but maybe not as emphasized as they are done so in this strategy. For example, the 10-10 societal enablers, aspects to do with sexual and reproductive health, access to affordable medicines, diagnostic and vaccines, also addressing the issue of equity there. So that's how the new global strategy is different from the old one. When you come now to HIV prevention, when you analyze the HIV prevention response, there were some key things that were identified to say these were the large gaps that we see, and these gaps are hindering our progress in achieving HIV prevention targets. When I showed you those 2020 targets saying what we were supposed to achieve and where we landed by 2020, why we landed where we landed, those bullets there, those 4 bullets are capturing some of the key things that were identified. First of all, limited political leadership in HIV prevention, limited policy and structural, there were also policy and structural obstacles to HIV prevention services, especially when you look at prevention services for key populations, a lot around social and structural barriers there. And then limited financing for HIV prevention programs. Usually when you're in discussion rooms and you need to prioritize, most of the times the money goes to HIV treatment, and there's less of emphasis on HIV prevention. Also, when you analyze HIV prevention and response data, you find that there are pockets of very good or successful programs in different locations. However, they're implemented at a very small scale. For example, when you look at PrEP programs, a number of countries supported by PEPFAR, they provide PrEP, but they're implemented as small projects, not national or nationwide programs. So limited implementation at scale is one of the big issues identified there. And then in an effort to address those, a new roadmap was developed, which you call the Roadmap 2025 or the HIV Prevention 2025 Roadmap. This document is a very concise document. Even myself, I learn every time I read it. Even I was part of the team developing it here at UNAIDS. It provides guidance to all countries and for all the different populations on how we can reduce new HIV infections and meet the 2025 target, as well as achieve the 2030 goal of ending AIDS. It sets out some principles. It suggests some milestones that countries can do if they're to be on track to achieve those targets. And countries can customize this roadmap into their own context if they're really to implement HIV prevention programs and aim to achieve the targets by 2025. In that roadmap, this slide is just summarizing what we thought success would look like in line with the global AIDS strategy. So success, it will mean people-centered precision prevention responses are being provided. 95% of people at risk of HIV, they use appropriate, prioritized, effective combination prevention interventions. And at the end, we want to make sure that we have less than 370,000 annual new HIV infections by 2025. That is the end goal. And how do we get there? 10 actions were suggested that if countries can work on these 10 actions, it can help them to get to the end point of fewer than 370,000 new infections per year. The first one being data-driven, designing programs that are informed by data. The second point, precision prevention, where countries are very focused in terms of the programs, the locations, and the different disaggregations they use in terms of targeting their interventions. Also, defining country investment needs to make sure that those programs are implemented at scale, and also strengthening leadership for HIV prevention responses, making sure that there's strong coordination, there's mapping and coordinating of the different partners that are supporting countries. Also, the fifth point is strengthening community-led HIV prevention responses. We saw during COVID that communities are powerful. When services are provided by communities, things move, people accept our services easily. So those innovations also from the communities that were started during the COVID, the roadmap emphasized to say it's good to strengthen them, it's good to implement them at scale, it's good to strengthen those innovations and support community-led HIV prevention services. And the sixth action is to remove social and legal barriers. We know, especially for key populations, this is a big thing, especially in sub-Saharan Africa, where some laws and policies they hinder the implementation or the access of HIV prevention services. Seventh action is promoting integration of HIV prevention. We know that throughout the HIV response, most of the programs have been done in silos, but to achieve efficiency, there is a lot of discussion around integrating services within other health services. And then making sure that countries are ready for the introduction of new prevention technologies. For example, recently there have been advances on PrEP, for example. Countries should be ensuring that they are ready, they've put things in place, they're generating demand ahead of time, and the necessary processes in terms of registrations for the new technologies are put in place in the country so that when they are available and ready, it won't take time to implementation. We saw how if these things are done concurrently, things can move quickly when we saw how the COVID vaccines were rolled out very quickly. And then monitoring, strengthening monitoring and reporting in real time, as well as accountability processes in check. So those are the 10 actions which they are clearly laid out in the 2025 HIV prevention roadmap. And there are suggested milestones which countries can customize to say, if you want to achieve data-driven assessments, we can do these things by these timelines, and we'll be able to achieve the set targets by 2025. Those actions, or the HIV prevention response, is categorized, or it's framed into specific pillars. 3 populations and 2 interventions. The 3 populations are a focus on key populations, which is the first pillar, and these populations are by their different categories, which are 5 categories according to UN's definition for key populations. And then adolescent girls and young women, adolescent boys and men. This is the pillar that used to be called VMMC before, but there's been discussions around broadening this part and making it a broader discussion on adolescent boys and men and addressing health needs of this population, not just the VMMC intervention. And then there's condom programming and ARV-based prevention as the 2 intervention pillars. So 3 populations and 2 intervention pillars, making up the 5 pillars of HIV prevention, is laid out in the new HIV prevention roadmap. The one I'm going to talk about is the one about adolescent boys and young men. Why focusing on this? It has become a very interesting topic lately, with a lot of interest from different partners, and also in many countries, they're so much interested in understanding this topic, because we have discussed quite a lot about the other populations and maybe paid not so much attention about men and adolescent boys. There is data. If you analyze the HIV estimates data, especially the cascade, testing, people on treatment, and viral load suppression, if you analyze it by sex, you find that men are lagging behind across those 3 cascade bars. Analyze program data from country, it also shows the same thing. If you analyze HIV transmission networks, there's data on phylogenetic analysis that is done by a group in Oxford. It still points also to the need to focus on HIV prevention for men, because it shows that men but up to 6 times more likely to transmit when you compare with their female counterparts of the same age groups. And these transmissions, they happen during acute infection, during the time when they don't know their status. And we know this from also the cascade estimate data that men are less likely to know their HIV status. So during early infection, when they don't know their status, that is the time most of the transmission are happening. That's what the phylogenetic analysis data is showing. And we know from WHO health workforce data, and some of the challenges why this gap is present has been unavailability of male-friendly health services. Most of the providers from the health workforce angle, they are women, and at times, depending on the service, at times men want to speak to men. So those are some of the reasons that we thought, okay, there is need for strong partnerships, strong coordination around this topic on men and HIV. And with the WHO units, we launched this group that we call MENT, standing for Men and HIV Technical Working Group. This group, it has got a smaller technical working group that is about maybe 30 people that provide some technical guidance to the larger group, where we conduct webinars and we review documents, we try to develop frameworks and those kind of things to support countries in scaling up approaches in engaging men. So basically, the MEN group coordinates activities related to improving outcomes for men. We also support development of operational guidance. We try to be a platform where we collect, we identify, we collect, and we share best practices that countries can learn from each other on tools, on guidance, and we help to disseminate these using that platform so that countries can learn from each other in terms of how they can engage men in closing that HIV services access gap. We run a series of webinars. This chart is just showing one of the typical webinars that we run. It's a largely attended group, and a lot of interest from people doing work on men and HIV, interested in sharing their work there. So people reach out to say, we are doing this about men and HIV, and we want to present at this platform. So we give them, we think of a theme, and then we give the different people with the work related to that theme to present during these webinars. We run them quarterly, and if there's need, we run some special episodes of these webinars depending on the topics. These are all the webinars that we have done so far, and I'm glad to say Julie has presented in one of the first or second webinars during this platform. Very interesting work around issues men face in their childhood and how that impacts in their health-seeking behaviors when they grow up. There's been a lot of interesting work shared here, from gender-related work to work to do with service access, you close to you campaigns, work on HIV self-testing, innovations on digital technologies used to reach out men. The last webinar we did in November was focusing on men and PrEP. Interesting work that was shared during that webinar. We are going to be resuming these webinars starting next year when people are back from holidays. For this year, the November one was the last webinar that we conducted. Just to give you an indication of the traction this topic is making. So at the meeting where I am now, the PCB meeting, which is called the UNAIDS Program Coordinating Board, so every time these meetings are done, a specific topic is chosen to be a thematic session to focus on that topic, to go into detail on that topic. And for this PCB meeting where I am now in Thailand, the thematic segment is focusing on men, on HIV and men in all their diversity, and how we can get the response back on track. It's going to be tomorrow. The session on this session actually is going to be done tomorrow. So as part of that process, there's a background document that is developed to go into detail, to provide the data gaps, highlight some of the approaches that works, that are highlighted during that session. So there's about 20-25 pages document that has been developed as part of this session. And there's a panel that tries to balance this topic in terms of men in all their diversity. So you find that in the panel, there are men from all the different populations, from key populations, from closed settings, be it prisons, from injecting drug use, MSM, and then the different approaches also addressing the different issues that men face. For example, the approaches to do it engaging traditional leaders, approaches to do it addressing gender norms, approaches to do it just making sure that services are convenient and available, approaches on workplace programs. And as part of this thematic segment as well, there's a request on submission of case studies from countries. There's been a lot submitted to UNAIDS. Some of them, we included them in the background notes, and some of them we're going to, because it was a lot, we had to put them in a separate document that we call a conference room paper. And then from that conference room paper, every year when we, or every time we write these global documents, global reports, be it the World AIDS report or the Global AIDS Update or any other report that we produce, we'll pull from those case studies to showcase them in those global reports that are widely read globally in terms of the HIV response progress. So I'm really excited and looking forward to this. A lot of interesting panelists from government, from prime ministers, from program supporting partners, from PEPFAR, for example, it's a mix, civil society, networks of people living with HIV, they're all making up this panel to discuss this topic tomorrow. So this is my last slide to just highlight to you what we have been learning on this topic about men and boys, or men and HIV, through the different work we have done, the different webinars we have conducted. These were some of our key takeaways. To say, when you think about men, think about diversity, that men come in different variety. We should understand the variety in men and how that implicates service delivery. We should think heterogeneous, we should think differentiated service models, and we should challenge some stereotypical thinking, or thinking that take men as perpetrators. Also, the issue of poor health-seeking behaviors should be looked at in context. Otherwise, maybe we need to look at our health systems designed to receive men. So there is also a need to challenge some narrative around men there. At the same time, they need also to challenge some harmful gender norms in some contexts that impact men's health-seeking behavior. When you think about men, think context, think local. Best solutions are local. One size does not fit all. Think evolving, and also think varied approaches and opportunities. When you think about men, think gender equality benefits men and women. This is a big discussion. When you talk about men and HIV, depending on the composition of the room, at times you get pushback. So it's important to know that when you're addressing HIV in men, it benefits both men and women. We saw this even from how HIV transmission dynamics happen. It will benefit both genders. And then when you think men, think ending AIDS, think partnerships, think inclusion, think implementation. When you think men, think all men. That's my last slide, and those are our concluding takeaways from the different work we have done so far on this topic on men and HIV. That's all I had for now, and back to you, Yepi, for any questions.
Thank you so much, Lysias. That was just a great overview, tour de force. And I turn it over to my co-chair, Natella, to kind of lead this next portion of the meeting.
Thank you so much, Julie. And thank you, Lysias, very much. You took us on a wind tour of the UNAIDS work overall, but was really focused on men. And I'm thrilled to hear about that working group with WHO. So while people are thinking of questions or any potential comments, and please feel free to put them in the chat or just raise your hand. I might not see everyone at once, Vivian and Julie. If I miss somebody, I'm trying to scroll through and if you want to make a comment, we can just, oh, here you go. We can just unmute you and you can speak. But I probably would start by saying, Lysias, I liked your comment about diversity, but also local. But what I wanted to challenge you is how to marry that need for local approach with a global approach. For example, some of the issues you raised, I was making parallels to our domestic epidemic, where we also have men is a big challenge in population, particularly young men of color. I am a pediatrician and I work with adolescent populations. And when I see some of my 16 or 17 years old patients, young MSM coming in with a third, fourth episode of STI or even syphilis at the age of 17, I know that we still are not doing enough within the community beyond HIV, comorbidities, etc. And I do know how much the challenges are there in their lives, anywhere from racism to adherence to ART that preclude the control of the disease that frequently is achievable in other populations. So as you pointed out, the outcomes are worse. So how would you comment on that need to be local, and yet there are so many similarities? And of course, the goal of our SIG is to generate this bridge between domestic agenda and what we do here in DC in international work. And I know you've traveled the world and you see the world from your lens. Could you comment on how to best, in your view, to find a way of marrying local agenda with a global agenda?
Thank you, Natalie. That's a good question. As you're asking, it just reminded me of the discussion on CSE. I was just sharing with Julie and Vivian when we joined the call link earlier on. There's a lot of discussion on how, because there are these global frameworks that UNESCO develops with other agencies on CSE globally to say this is what countries should be offering in school or out of school when it comes to CSE. But then countries, depending on context and regions and cultural differences, they then come and say, no, the recommendations should be cultural specific. But then when you say culturally relevant CSE and leave it like that, it will leave room for either a country, depending on what they mean by culture, to take it out completely, the essential elements, and then it's no longer really CSE in line with what data would have shown when the global guidelines were developed. So it's a very interesting question that applies even to other different interventions. When we want to say, how should we marry the global views to the local, as we know local is the best? I think it's good to show, maybe when you go to the different regions, it's good to show what the global data is showing. Highlight these guiding frameworks. For example, we have got the roadmap 2025. It's a global document. It tries to look at things, how they are relevant across the different parts of the world. But then when we go to a country, we share this document, right? And then we say, you need to customize it into your own context, depending on your local epidemic. For some country, when they take, for example, if Iran is going to take that roadmap 2025, they're going to tell you that a GYW is not applicable in our country. But if you take it to South Africa, they'll tell you that that pillar is very specific. Adolescent girls and young women, we need to really focus on that pillar strongly. It's the main thing for them. If you go to a different country in Eastern Europe and Central Asia, they'll tell you the key populations for us is the big thing. So I think it's important, when you go to the different locales, to try and make people understand how the global frameworks are developed, or how the global picture is getting its information from, and try to understand their local epidemic so that they can use the global frameworks to guide their own local response. And when they are customizing these global frameworks into their own local frameworks, I think to let them lead, it's a good thing, or to do it in consultation with them so that they make suggestions into how they can translate those global frameworks or the global picture into their own local context. I think that's how it can work without losing what the global documents are trying to achieve, but in a local context. I'm not sure if I fully answered the question, but that's my thinking from how I used to see, because I used to work in South Africa before I came to Geneva. So when I used to compare how at times these global documents are presented in countries, and then now that I'm the one who have to be sharing them, and the preference of countries in terms of they understand their epidemic more than maybe how people at the global centers understand it. I think doing things in consultation with them, at the same time trying to make them understand how these global documents are developed and where the data is coming from, what it means, and how they can translate that to their own local context depending on their epidemic, and allow them to lead that exercise. It can help, I think, to marry the two. They can still see the relevance of that global picture or global actions in their own local specific context. Yeah.
Thank you, Lysis. And I think you really highlighted the need to study the implementation process. To me, some of your comments really highlighted, we have evidence, we come with these guidelines, where are the barriers to implement them, and are these barriers similar across the board or not? And what are the best facilitators? Is the community an answer across the board, or to which percent the community can be an answer? So I think you just highlighted something we all struggle with, is our capacity to measure the uptake and implementation of this evidence into real world settings, and then measuring definitely the outcome. And I think our global SIG is trying to take that direction forward, where we can find a common ground between the work done here and looking more at implementation element and comparing at the implementation, because I think on the human factor level, you can actually find more similarities than on the systematic or external factors when talking about the HIV epidemic. I see Julie online, and I wanted to give her a chance to comment, and then we will be moving away from Q&A just to give you a little bit overview. And while we have you online, Lysis, and all other members attending today, asking you to do some homework for us for January, to think about some technical areas where we would like to take the collaboration forward with DCCFAR and global partners. Julie, do you want to comment or make a question while Lysis we're wrapping up around his presentation? Oh, I see Alan raised hand. Alan, why don't we give you priority?
No reason for priority, but thank you for a wonderful presentation. One of the issues that we see very much so here locally is so many people working on HIV/AIDS, be they working as community workers, or we as academicians, or people working in government, or clinicians, that we've been pulled to contribute to the response to so many other epidemics in the last couple of years. And you know, of course, as well as we do, monkeypox, mpox, COVID, and others. And it's been a challenge for us as individuals to maintain our focus on HIV, and it's been a challenge for organizations to prioritize HIV, as so many other things have been happening. I'm just wondering, from your purview, both at UNAIDS and your observations globally, how has that affected our colleagues in Geneva, and how has that affected our colleagues around the globe? Thank you.
Yeah, great question. It's really a great question, because over the last few years when COVID started, I worked quite a lot. I was coordinating the COVID response in UNAIDS as well. So interesting question. It definitely took a lot of time. It took a lot of time, staff time, in addressing the other epidemics. However, I think the way we tried to leverage in UNAIDS was to say, what can we learn from the HIV response that could be applied to these other, in this case, COVID or monkeypox, for example. That way, I think it was a quick way to not try and come up with the new things or new ways of addressing the new epidemics, but to draw from what we already know. For example, when it comes to human, we know, like in a public health a crisis, there are certain measures like restricting people movement. We know it doesn't work to restrict people from moving from one country to the other. It does not work. And drawing from those things that we learned from the HIV response, having laws in place that restrict access to services, we know it doesn't work. So drawing from those lessons that we learned from HIV and just applying them to the current crisis that we are facing, it was an easier way to not start afresh, or to not start to create new ideas about how we can respond to the new epidemics. But yeah, a short answer to your question, it definitely took some time. It also definitely took some resources as well. I think you might be familiar that even with the Global Fund, there was the COVID-19 response mechanism that was put in place in trying to mitigate the impact of COVID on the HIV, TB, and malaria responses. That was a lot of money that went into that could have gone into these three diseases, for example. So yes, it impacted in terms of the resources, in terms of the human capacity to do the work to respond to the crisis at hand. It also impacts in terms of how the health systems are set up as well. Like, for example, for HIV, a number of facilities or sites that were providing HIV services, they had to stop doing that and start to do or to provide services for COVID-19, for example. Some interventions that could not be done in the context of COVID. For example, male circumcision, people could not go through a surgical procedure during COVID. They had to stop that and they had to use the facilities that were being used for that to provide services for COVID. So it does impact, I think, in different ways, in resources, in our in the human capacity, in terms of I think the capacity of the infrastructure that is available to provide services for the HIV response now being diverted towards the new epidemic. Yeah, I think that's my quick response to your question. The key thing is to try and leverage what you've already learned in one epidemic and apply it so that you don't lose much time in creating new solutions for the new epidemic. Yeah.
Thank you for sharing your perspectives. That was very interesting.
Julie, for you to make a comment before we move on to our slide of priorities, would you like to please? So you've been referenced several times with the webinars as well, and so maybe you want to make several comments.
Just sensitive to the time, just to thank Lysias, because I imagine he's going to want to jump off since it's 10 o'clock at night his time, 11 o'clock. Thank you very much for joining us, and to highlight again that wonderful set of webinars that they have for the Men in HIV program, and that there's a lot that I think we could be joining on the global level, the folks in the DCCFAR, to get connected and to see what's happening across different regions and what are some of the priorities, where we sit, where we could inform both global response and we could take some of the priorities and bring them to the DCCFAR setting. So I think it's a great connection. Thank you again, Lisa.
Thank you, Lysias. And what we wanted to do today before we adjourn, we have about 10 minutes left and we have quite a few attendees. Thank you all for finding time on busy Thursday morning to join us. While we still have Lysias online and everyone, we wanted to remind you of some of the technical priorities. Vivian, if I can ask you to project that slide, that we have identified through the CFAR-wide survey of the people who expressed interest in doing global work within the DCCFAR network. So finding this bridge of which we talked between national and international agenda, and just briefly remind you these areas of interest. And while we have you online, if anybody has any particular comments on these areas of interest, we would be delighted to hear them. But Julie, myself, Khadija, and Vivian wanted to ask you to go over them with us right now and to think, because starting January 2023, it is our goal of our SIG to start really working on the concrete proposals for the research that will encompass global agenda and domestic agenda, and would allow us to move along one or two of these priorities. We are not too ambitious to grab all of the bullet points on the slide, but clearly some of the areas of interest have been emerging through the conversations that we have had with members and survey. Clearly, our focus is on social structure factors. We just heard Lysias going over a lot about diversity and looking at the diverse gender norms, violence, power dynamics, intersectional stigma. That is one direction to take, where we could draw on some parallels and comparisons within the work done here with global partners. And it can be one global country partner, or it can be several partnerships. And Julie and I are here to facilitate this liaison. So we have people who are working in different domains within CFAR, from academia to the global organizations, and liaising with the bodies like UNAIDS and others would be really very useful collaboration. And we see a lot of opportunities there. The second domain was interventions. and looking at the communicating the behavioral changes, social structures intervention, and community empowerment. And the community has been seen on several slides that Lisha shared today, focusing on men as well. Now, finally, moving technologies, we didn't touch on that today, but we talked a lot about prevention, and prevention is changing radically. We are moving away to the domain of injectable PrEP, long-acting ART. So looking how these are applicable, how this will affect our prevention landscape, with a focus on diverse population, on key populations. Comorbidities, here they've been mentioned some, and we just talked about the challenge that COVID posted, but we have a lot of work going on already in our CFAR, looking at the mental health, substance use. Are there any joint projects we could be developing with global partnerships? Methodological approaches, a lot of attention recently has been looking at geospatial assessment and implementation science. And I think it goes a little bit to the comment I made earlier, marrying local agenda with evidence and global journal guidance. What are geospatial factors that we need to take in account when rolling those out? And then we are really happy to create small subgroup of interest. If anybody wants to have a more narrow discussion with certain populations that are listed in the bullet subgroups of interest, we are happy to have dedicated sessions. Julie and Ulysses obviously brought us to very high level of understanding the challenges within male populations most recently, but there are others, and then definitely with children and youth, I would be happy to take the lead, and many others listed here. We have quite good expertise built up within CFAR already, and if we need to pull players and other SIGs and other experts within the team, Julie and I and Vivian and Khadija will do that to create small discussions. But we want to encourage you to think about this and reach out back to us. And we will be inviting you in January to sit together and brainstorm and really try to concretely link people on. And obviously the last bullet you could not bypass on this slide, looking at geographical settings. There are areas where there are already established collaborations, but we are very open to open new channels of collaborations. So if you have some projects or you are interested in working in certain regions, we want to hear from you, because we will make and facilitate these connections for you. And if you are doing the work locally, but you want to work in sub-Saharan Africa, Juliana and Khadija and Vivian will meet with you individually. We will landscape what your interests are, and then we can move this forward. DCCFR has been an incredible resource, and by Alan and Brenda Online, I just want to recognize exponential growth of that collaborative NIH-funded, I don't know even if I can call it network body, that really changed the way we do research here in our area. And our goal today, and I will let Julie also make a few comments on this, is for you to take these priorities home with you. We're happy to share them as a separate email for the attendees, just to remind you of those, and we will share it wider within SIG group. Please think of those, and we would love to hear from you with some concrete ideas, or at least desire to do some work in this area that we can take forward. If you don't have yet a very concrete idea, but you say this area interests me, that's a good start for conversation that we can take forward. Julie, to you, to make sure I didn't miss anything.
Thanks so much, Attila. The only other point that I would add is we do want to prioritize having the opportunity to develop new collaborations and think about areas of research and even specific opportunities and proposals. But I would also add there are other ways that we can collaborate, such as thinking about writing a commentary together, or thinking about writing papers together based on work that you're already engaged in that might be bringing a new perspective in collaboration with another team member on Global SIG or with us. That could be another area as well. So we're looking to find ways. We hope to meet every month, once a month, at least probably 1 month on areas that we can work on together and getting updated amongst each other. And the opposite month more about having a presentation like Alicia has just shared with us and discussion. So that's what we had originally started talking about for 2023, and we're open to, we'd love to have you join and to bring colleagues. I know there are some colleagues who are not able to join today who wanted to, at least perhaps partly because of our huge sleet and rainstorm and everyone having to take their children in late in different areas in the region. I know that happened and to several of our colleagues. So we're looking forward to bringing together the group in a variety of ways. And that this list came about from the initial survey that was sent out for all those who are interested in the global SIG, but we're open to other topics too that you'd like to bring to us. So just want to say thank you. And I don't know if we have a couple of minutes if anyone wants to throw out a suggestion or two, or we should close here, but I think I see a hand.
Oh,
And
Julie, I
Brandy.
wanted to, yes, I just wanted to make a plug. And Lysias, thank you so much for your presentation and thanks for having us today. As you're thinking about, potential proposals, I just wanted to mention that the DCCFAR Pilot Awards program will be releasing the spring call for proposals at the end of January. And so that's something you all may want to think about. Our early stage investigators from our 9 institutions, as well as new investigators from our institutions, are eligible to apply for up to $50,000 for HIV/AIDS priorities. And so Vivian also is the developmental core manager, so she can give you more information on that. And you can also have someone from the developmental core, Lorena, the senior research program manager, and maybe a core director come to speak to the group a little bit more about the Pilot Awards program and the priorities and the process, if that would be something of interest. But I just wanted to make that plug in so you can think about that in terms of somewhere that you can apply. You can apply right here to the DCCFAR.
And can I ask Brandy, do we have a sense of is there going to be a supplement as well?
The supplements will come directly from NIH, and those are typically released in, I think it's March, April timeframe. And so we won't know exactly, what those are, what those calls are until they're released from NIH then, but we will certainly let everyone know. We usually put out, big announcements and ask for concept sheets from our investigators when that time comes.
And I think, thanks so much, Brandy. And I think, Alan, did you have an additional comment?
No, if Brandy could just add about the Transitioning Investigator Award.
Yes, and also this cycle, we are going to host another Transition Investigator Award, and that is for up to $100,000 for senior investigators in other fields who do not have R01s in HIV/AIDS. And we'd like to bring them into the fold and bring them into the DCCFAR so they can use all of their skills and knowledge on whatever else they're working on, whether it be diabetes, cardiology, but to meld that work with HIV/AIDS. And Vivian is actually helping put together a very long list of R01 funded investigators from our institutions who would be eligible, and we'll be sending them the call for concept sheets, I think in mid-January. But again, those are for up to $100,000 for 1 year.
Okay, thanks so much. And perhaps, Natella, if all right with you, Lysias has his hand up. Maybe he can have the last word of the meeting.
I saw Lysias holding hand.
Thanks. Thank you so much. As I see this list, I think we can exchange on a number of them. From the first one up to the last one, I can think of 1 or 2 things, and maybe specific teams here at UNAIDS. I can maybe link the team there with maybe for further discussions and maybe coming up with some concrete things to do. For example, the long-acting piece, there's a coalition access to long-acting. I don't know if you know about it. There's a coalition that is being, the secretariat is AVAC, but it's got UNAIDS and the WHO there and some partners on pushing for access to long-acting technologies. At the moment, there's a focus on PrEP. I know at UNAIDS, we have a team called integration team that is working on cervical cancer, TB, and mental health issues. The pediatrics work as well. Adolescent girls and young women, there's a lot there we can do. There are some global groups which I think you could be part of those groups discussing or developing decision aids for programs for adolescent girls and young women. I think from the work you have been doing on AGYW, on DREAMS, I think it could be a very good platform to have a voice in that, because coming up with what are the access platforms for different services, how you can prioritize under limited resources, looking at data, HIV incidents, which also speaks maybe you could link to the geospatial work that you are doing. and we have got offices in all those regions that you highlighted in your last point there. I think, yeah, let's find time we can exchange, and where it does not link directly to me in units, I can link you up with the specific people that are doing something interesting that you could be part of as well. Yeah.
Thank you so much, Lysias, and thank you to the group for joining us today. It was great to see you all, and looking forward to continuing in the new year. Have a wonderful end of year.
Happy holidays to everyone.
Happy holidays.
Yes. Bye-bye.
Take care.